Welcome, curious minds, to another deep dive.
Great to be here.
Today, we're embarking on a really fascinating and incredibly important journey. We're looking into what happens when our bodies encounter toxic substances or, foreign invaders.
Right. It's all about the body's response and, crucially, how medicine steps in.
Exactly. It's a look at the precise medical knowledge that not only diagnoses these encounters, but also, well, provides the pathways to healing.
And our sources today give us a really solid overview covering both gastrointestinal reactions and wider systemic effects.
They do. So our mission today is to unravel these complex medical scenarios. We want to focus on the specific ways substances can harm the body, and just as importantly, the equally specific countermeasures that medical science has developed.
Countermeasures are key.
Absolutely.
Sure.
Okay, let's unpack this. We're starting our journey with the esophagus,
Hmm.
that vital muscular tube connecting the throat to the stomach.
The first point of contact for anything we swallow.
Right. And it's truly incredible how many distinct conditions can affect it, sometimes from the inside, sometimes from external irritants.
It's more complex than it looks.
Definitely. Let's kick things off with eosinophilic esophagitis, often just called EOE.
Ah, yes, EO.
This condition is particularly interesting because it's actually an allergic inflammatory response.
It
Directly affects the lining, the epithelium of your esophagus.
Think of it like localized allergy right there.
Yeah.
Triggered by food, usually, or maybe environmental stuff like pollen.
An allergy in your throat, essentially.
That's a good way to put it. And it's not super rare. We see it most commonly in children, and it often goes hand in hand with other atopic diseases.
Like asthma, eczema, that
True.
sort of thing.
Exactly. Hay fever, too. But what's interesting is we're also seeing it more in white males, typically between 30 and 40 years old.
Huh. That's a specific demographic shift.
Yeah.
And the symptoms, they vary quite a bit depending on age, right? That must make diagnosis tricky sometimes.
It really can. For adults and teenagers, the usual complaints are esophageal dysfunction. So difficulty swallowing solids, that's dysphagia, or even food getting physically stuck. Food impactions.
Wow. Sounds alarming.
It can be quite distressing. But in younger children, the signs might be, well, less obvious. Feeding difficulties, maybe refusing food altogether.
Picky eater, maybe?
Sometimes mistaken for that, yes. Or symptoms that look a lot like reflux, maybe abdominal pain.
I can see how that might get missed or maybe misdiagnosed initially as just standard reflux, especially in kids.
That's a definite challenge. Diagnosis often needs an endoscopy, a small camera to look inside the esophagus.
What he's looking for.
Well, sometimes it might look surprisingly normal, but often we see specific changes. Things like multiple corrugated rings, almost like stacked circles.
Corrugated, like cardboard.
Sort of, yeah. Or strictures narrowings, especially higher up. We might also see these tiny whitish exudates or papules.
What are those?
They're actually little collections of eosinophils, those allergic immune cells, microabscesses, essentially. Other signs can be a loss of the normal blood vessel pattern because of swelling, or these linear furrows, like grooves.
Okay.
But the definitive diagnosis, that comes from a biopsy. We take small tissue samples during the endoscopy.
And look under a microscope.
Precisely. We're looking for a high count of eosinophils. The standard is 15 or more per high power field, or HPF. That confirms the specific allergic inflammation.
Got it. So once you have that diagnosis, what's the management plan? Especially if diet is the first step. Changing your diet long-term sounds, well, tough.
It can be a significant adjustment, absolutely. Dietary therapy is usually the first-line approach for both kids and adults.
How does that work?
Often it starts with empirically eliminating the most common food allergens, the big six or big eight: milk, wheat, egg, soy, nuts, seafood are typical.
Taking them all out at once?
Usually, yes. Then you systematically reintroduce them one by one to pinpoint the actual trigger foods for that specific person.
Okay, that makes sense. What about medications?
We have options there too. Proton pump inhibitors, PPIs. The acid reducers are actually a good first-line pharmacological choice. They can clear up the inflammation in maybe 30 to 50% of cases.
Even though it's allergic, not acid-related.
It seems counterintuitive, but yes, they can be effective. For symptoms that don't respond, we can use topical glucocorticoids, like swallowing budesonide slurry, which acts directly on the esophageal lining to reduce inflammation.
Apply it right where it's needed.
Exactly. And if someone develops fibrostenosis, that's hardening and narrowing from chronic inflammation, esophageal dilation can help relieve the difficulty swallowing, though you have to be careful there's a slightly higher risk of perforation with dilation in EOE.
Right, makes sense. Okay, so beyond allergies or food reactions, the esophagus can also be irritated by, well, things we take intentionally, like pills.
That's right, pill-induced esophagitis. It's exactly what it sounds like, damage caused by a pill sitting too long against the esophageal lining.
Just getting stuck there.
Pretty much. And certain medications are more likely culprits. Antipsychotics, like ibuprofen or aspirin, are common ones. Also, bisphosphonates for osteoporosis.
Okay.
Beta blockers, calcium channel blockers, potassium chloride tablets, those big ones, iron pills, some antibiotics like tetracyclines, even vitamin C and zidovudine.
Quite a list.
Yeah.
And the symptoms sound similar to other esophageal problems.
They do. Adenophagia, painful swallowing, dysphagia, difficulty swallowing, and that retroesternal chest pain right behind the breastbone.
How do you diagnose that specifically?
Endoscopy again. We typically see small, well-defined, separate ulcers. They can be shallow or deep, usually right where you'd expect a pill to get held up.
And the fix.
It's often wonderfully simple, but crucial. Always take pills with plenty of water, at least 4 ounces.
Just wash it down properly.
Exactly. That helps ensure it doesn't linger in the esophagus.
Such a basic thing. I bet a lot of us just dry swallow pills sometimes without thinking. A little water could prevent a lot of pain.
It really could. Simple preventative measure.
Okay, so we've covered allergies, irritants like pills. What about actual infections invading the esophagus?
Yes, infectious esophagitis. Now, this is often seen in people with weakened immune systems, maybe HIV, post-transplant, cancer patients on chemo, people on high-dose steroids.
Makes sense.
And this is important, it can also happen in people with perfectly healthy immune systems, so you can't rule it out just based on that.
Good point. And the symptoms are those classic 3 again.
Yes, the triad. Odenophagia, painful swallowing, which is really the hallmark, often severe. Then dysphagia, difficulty swallowing, and retroesternal chest pain.
Got it. Are there common culprits for these infections?
There are a few main ones, and they tend to look different on endoscopy, which helps with diagnosis.
Okay, like what?
Candida, a yeast, is the most common. Endoscopy usually shows lineal yellow-white plaques or patches. Kind of looks like thrush, but in the esophagus.
No. Okay.
Biopsy confirms it. You see the yeast cells and pseudohyphae invading the tissue. Treatment is usually straightforward. Oral or IV fluconazole.
Right. What else?
CMV, cytomegalovirus. This tends to cause large, shallow ulcers. They might be linear and generally look deeper than what you see with herpes.
And the biopsy.
Very characteristic. You look for cells with inclusions that have this owl's eye appearance. It's a classic sign of CMV. Treatment here is typically IV ganciclovir.
Owl's eye. Interesting. And the third?
HSV, herpes simplex virus. This often causes small vesicles like little blisters or these deep sort of punched out ulcers, sometimes described as looking like volcanoes.
Volcanoes. Wow.
Yeah. And the biopsy also has telltale signs. Cowdrey bodies, which are specific nuclear inclusions and multinucleated giant cells. First-line treatment is acyclovir, either oral or IV.
It's amazing how distinct those clues are for identifying the specific bug. Okay, so we've zoomed in on the esophagus. Let's zoom out now. How can toxic substances affect the entire body, particularly the nervous system?
This is where we get into the autonomic nervous system, that constant balancing act between sympathetic and parasympathetic activity.
The fight or flight versus rest and digest.
Exactly. Sympathetic, largely driven by norepinephrine, gets you ready for action. Parasympathetic, mediated by acetylcholine, handles the housekeeping, digestion, slowing down, that sort of thing.
Right, controlling things we don't consciously think about.
Precisely. And for the parasympathetic side, mediated by acetylcholine, there's that handy mnemonic SLUDDC.
Ah yes, SLUDDC. Remind us.
Salivation, lacrimation, tearing, urination, digestion, defecation, and constriction of the pupil. It covers the main parasympathetic functions.
Okay, so what happens when that system goes into overdrive? Let's talk cholinergic toxicity. What causes that?
Cholinergic toxicity means too much acetylcholine activity. Often it's caused by substances that block the enzyme that normally breaks down acetylcholine. That enzyme is acetylcholinesterase.
So the acetylcholine just builds up.
Exactly. Common culprits are insecticides, organophosphates, and carbamates are the big ones you hear about in pesticide poisoning. Certain medications can do it too, like drugs used for myasthenia, gravis, pyridostigmine, neostigmine. They are acetylcholinesterase inhibitors by design. And unfortunately, nerve agents like sarin gas work this way too.
How does exposure happen?
It can be through skin contact, inhalation, or swallowing the substance.
And the effects? If SLUDDC is normal, What does overdrive look like? What are the really dangerous signs?
The effects are profound and hit multiple systems. The most critical danger is respiratory failure. That's the most common cause of death.
Why respiratory failure?
You get bradycardia, slow heart rate, but also massive amounts of airway secretions called bronchuria and bronchospasm, where the airways constrict. It becomes incredibly hard to breathe.
Okay, that sounds terrifying. What else?
Well, those muscarinic effects are essentially SLU-DDC turned up to 11, intense salivation and sweating, lots of tearing, uncontrolled urination and defecation, diarrhea, GI cramps, vomiting, and the pupils become tiny pinpoint pupils or meiosis,
Wow, all liquids flowing.
pretty much. Then you have nicotinic effects, which involve the muscles, fasciculations, those are visible muscle twitches, muscle weakness, potentially leading to paralysis, kind of like succinylcholine. You can also get seizures, weirdly, sometimes tachycardia and high blood pressure, too.
So fast heart rate and slow heart rate.
It can be confusing. The muscarinic effects tend towards bradycardia, but strong nicotinic stimulation can sometimes cause tachycardia. And then there are CNS effects, central nervous system, central respiratory depression, lethargy, seizures again, and coma. It's a complex picture.
It really is. What's fascinating, though, is how the treatment seems so specifically designed to counter these effects.
They absolutely are. Management is very targeted. First, decontamination is vital. Get the stuff off the skin, out of the system if possible. Vigorous washing for skin exposure. Oxygen is crucial.
And the drugs.
The key antidote is atropine. You give large doses and you titrate it, adjust the dose until those respiratory secretions dry up and the bronchoconstriction eases. Atropine blocks the muscarinic receptors, hitting that SLU-DDC overdrive.
Okay, so atropine handles the muscarinic side. What about the nicotinic, the muscle stuff?
For organophosphate poisoning specifically, you also give an oxym, like pralidoxim, often called 2PM. This should be given after or with atropine. Pralidoxim actually reactivates the cholinesterase enzyme that the organophosphate inhibited.
So it helps break down the excess acetylcholine.
Exactly. So it helps with both muscarinic and nicotinic symptoms, like the muscle weakness. And if there are seizures, benzodiazepines are the treatment.
Right. Okay, so that's too much acetylcholine. What about the opposite? When acetylcholine is blocked, anticholinergic toxicity.
Right. This is when the action of acetylcholine is inhibited. It's often caused by medications that have anticholinergic side effects.
Like what kind of meds?
Lots of common ones, actually. Many antihistamines, especially older ones. Some antipsychotics, antidepressants, drugs for Parkinson's, antispasmodics used for gut cramps, even mydriatics, the eye drops used to dilate pupils.
So if SLEDDC is the effect of acetylcholine, blocking it gives you the opposite.
Precisely. The classic mnemonic for anticholinergic toxicity describes the symptoms perfectly. Anti-SLU-DDC, essentially.
Okay, lay it on us.
Dry as a bone, dry mouth, dry skin because you can't sweat anhidrosis, decreased tearing, blind as a bat, pupils are dilated wide, mydriasis, and don't react to light.
Got it.
Red as a beet, skin is flushed and dried due to cutaneous vasodilation, blood vessels widening near the surface. Hot as Hades fever, partly because you can't sweat to cool down.
Dry, blind, red hot. What else?
Urinary retention, can't pee, decreased bowel sounds, constipation, tachycardia, fast heart rate from unopposed sympathetic activity, that beta-1 effect. And finally, mad as a hatter.
Ah, the CNS effects.
Yes, delirium, hallucinations, anxiety, agitation, disorientation, confusion, sometimes psychosis, coma, and seizures can also occur.
That's a striking picture. Diagnosis is mostly based on recognizing these signs.
Primarily, yes. It's a clinical diagnosis based on that constellation of symptoms and hopefully a history of potential exposure to an anticholinergic agent.
And management.
It's mainly supportive care. ABCs, airway, breathing, circulation. Treat agitation or seizures with benzodiazepines, just like in cholinergic toxicity. GI decontamination, like activated charcoal, might be useful if the ingestion was recent.
Is there a specific antidote like atropine for cholinergic toxis?
There is, but it's used cautiously. Physostigmine, it's an acetylcholinesterase inhibitor that can cross into the brain so it reverses the effects centrally and peripherally.
Why? Cautiously.
It can cause its own problems, like seizures or bradycardia, if given improperly or too quickly. It's generally reserved for severe cases like coma, intractable seizures, severe agitation not responding to benzos, or dangerous hypotension. Plus, it's often hard to get. There have been ongoing manufacturing shortages, which is a real problem in clinical practice.
Okay, moving beyond the nervous system tug of war, let's talk about some other critical ingestions. It's really striking how different substances have such specific, sometimes dramatic effects and require equally specific interventions.
Absolutely. The mechanism of toxicity varies hugely. Let's start with a really common one, acetaminophen, paracetamol.
Found in almost every home. How does it become toxic?
In overdose, the liver's normal pathway for metabolizing it gets overwhelmed. Specifically, it depletes a substance called glutathione. Without enough glutathione, a toxic byproduct builds up and causes hepatic necrosis, liver cell death.
Ouch. What does that look like clinically?
Initially, it might just be anorexia, nausea, vomiting, maybe sweating diaphoresis. Pretty nonspecific.
Could be mistaken for a stomach bug.
Easily. But then, over hours to days, it progresses. You get pain in the upper right quadrant of the abdomen where the liver is, jaundice, yellowing skin and eyes, and problems with blood clotting, coagulopathy, because the liver makes clotting factors.
And the specific countermeasure.
N-acetylcysteine, often called NAC. It acts as a substitute for glutathione, helping the liver detoxify that harmful metabolite. Activated charcoal can also help if given early, within an hour or so, to reduce absorption.
Okay. What about salicylates?
Mm-hmm.
Like aspirin, but also Pepto-Bismol, oil of wintergreen.
Right. Salicylate toxicity is complex. It does a couple of distinct things to your acid-base balance. First, it stimulates the respiratory center in the brain, making you breathe fast.
Hyperventilation?
Exactly, which blows off CO2 and causes an initial respiratory alkalosis. The blood becomes too alkaline.
Okay.
But then the salicylate itself disrupts metabolism, leading to the buildup of acids, causing a high anion gap metabolic acidosis. So you often see this mixed picture.
Alkalosis, then acidosis. Complicated.
Other symptoms.
Oh, yes. Fever is common. Hypokalemia, low potassium, because you lose it in the urine. CNS effects are serious. Seizures, coma, encephalopathy. Renal failure can happen. Pulmonary edema, fluid in the lungs.
Sounds like a systemic assault. Management must be intensive.
It really is. ABCs first, always. GI decontamination with activated charcoal, maybe gastric lavage.
Right.
A key treatment is alkalinization, giving intravenous sodium bicarbonate.
Why bicarbonate? Making the blood and urine more alkaline helps trap the salicylate in the bloodstream and promotes its excretion by the kidneys. 4V fluids are also vital. And for severe cases, hemodialysis is the way to go. It physically filters the salicylate out of the blood.
Dialysis makes sense for severe poisoning.
Yeah.
Okay, let's talk about bases. Corrosives like oven cleaner, drain cleaner, bleach. These sound immediately dangerous.
They are. The primary risk is liquefaction necrosis. They basically dissolve tissue on contact. This can lead to perforation, burning a hole right through the esophagus or stomach. Epiglottitis, swelling of the epiglottis, can also happen rapidly, blocking the airway.
Terrifying. What's the immediate first aid or management?
Supportive care is key. Secure the airway if needed. You can give a small amount of water or milk as a diluent, just to rinse and dilute slightly.
Okay.
But, and this is critical, do not induce vomiting. Do not use gastric lavage. And absolutely do not try to neutralize the base with an acid. That generates heat and makes the burn much worse.
Right, avoid making it worse. What about hydrocarbons? Things like gasoline, benzene, petroleum, kerosene, motor oil.
With hydrocarbons, the main worry isn't usually swallowing them, although that can cause GI upset. The big danger is aspiration, getting even a tiny amount into the lungs.
Causes lung injury.
Yes, chemical pneumonitis, inflammation of the lungs, that's the primary danger. Clinical signs might include rapid heart rate, fever, CNS depression if a large amount was absorbed, irritation of the mouth and throat, maybe vomiting or bloody diarrhea.
Management.
Mainly supportive. Watch the breathing closely, provide oxygen. Antibiotics if a bacterial pneumonia develops on top of the chemical pneumonitis. And again, avoid emetics or lavage. You don't want to increase the risk of aspiration.
Okay. Another common one. Iron. From supplements, usually.
Yes, iron pills are a common cause of poisoning, especially in children. Too much iron is corrosive to the GI tract and can also cause systemic problems.
What kind of symptoms?
Nausea, vomiting, often bloody, abdominal pain. In severe cases, shock, coagulopathy, those clotting problems, again, liver damage, and sometimes reddish urine.
How do you treat iron overdose?
Emesis might be induced, or gastric lavage. Sometimes whole bowel irrigation is used, especially if pills are visible on an X-ray, to flush them out.
Is there an antidote?
Yes, there's a specific chelating agent called deferoxamine. It binds to the iron in the bloodstream, allowing it to be excreted in the urine. Hemodialysis might be needed in very severe cases, too.
So looking across all these acetaminophen, salicylates, bases, hydrocarbons, iron, it really underscores your point. Different poisons, different mechanisms, different, often very specific treatments.
Exactly. It shows how crucial it is to identify the substance, if possible, because the management can be so specific.
It highlights the precision involved. You mentioned specific antidotes for iron and acetaminophen. Are there other common poison antidote pairs we should know?
Definitely. Toxicology relies heavily on specific antidotes when they exist. For example, tricyclic antidepressants can cause severe cardiotoxicity. The antidote is sodium bicarbonate,
Okay.
opioids, heroin, fentanyl, prescription painkillers. The antidote is naloxone, which reverses respiratory depression very quickly.
A lifesaver.
Truly. Benzodiazepines like Valium or Xanax. In severe overdose causing coma or respiratory depression, flumazenil can be used, though cautiously.
Right.
Beta blockers, which slow the heart. Glucagon is the antidote. It bypasses the blocked receptors to stimulate the heart.
Interesting.
Ethylene glycol, that's antifreeze, highly toxic. IV ethanol used to be the main treatment, but now flumpazole is preferred. Both block the enzyme that converts ethylene glycol into its toxic metabolites.
Stopping the poison from forming.
Exactly. Warfarin, the blood thinner. The antidote is vitamin K plus fresh frozen plasma or prothrombin complex, concentrates to quickly replace clotting factors if there's active bleeding.
Got it.
And heparin, another anticoagulant. The specific reversal agent is protamine sulfate. Each one targets a specific molecular interaction. #tag outro.
Wow. We have covered an incredible amount of ground today, from very localized issues affecting just the esophagus all the way to widespread systemic toxicities impacting our nervous system, our liver, our blood clotting, pretty much everything.
It's a huge range, definitely.
It really hammers home the value of understanding not just what a substance does, but how it does it. The mechanism is key. And knowing that mechanism allows for these precise, sometimes incredibly specific interventions we've talked about.
That specificity is often what saves lives. General supportive care is always important, but the targeted antidote or treatment can make all the difference.
It's truly a shortcut, isn't it? Being well informed about these hidden dangers and the, frankly, remarkable solutions the human body and medical science have come up with.
Absolutely. This deep dive really demonstrates how that precise medical understanding of the underlying mechanisms, the how and why, is just fundamental. It's the basis for effective intervention and ultimately for saving lives. It's the power of targeted knowledge in action.
So as we wrap up, here's a final thought. We've seen just how complex and specific the body's responses to these, often acute, exposures to foreign substances are, and how specific the countermeasures need to be. What if? What if we applied that same level of precision to understanding how other, maybe more subtle daily inputs, things like our diet, our environment, maybe chronic, low-level exposures might be causing gradual long-term shifts in our physiology, shifts that perhaps we're only just beginning to truly grasp?